Hello and welcome to this Ask the Expert session, where I'll be answering several of your questions centering on the management of severe asthma. I'm Dr. Micheal Weschler, Professor of Medicine and Director of the National Jewish Cohen Family Asthma Institute at National Jewish Health in Denver, Colorado. Let's get started. First question. Well, the diagnosis of asthma involves both taking a good history, evaluating spirometry, and looking at specific biomarkers and other comorbidities. When making a diagnosis of asthma, one should first evaluate for airflow obstruction, and that should be done with spirometry. In the absence of airflow obstruction, one can induce some degree of airflow obstruction by performing what's called a methacholine challenge, in which increasing doses of methacholine are administered, and then we evaluate to see whether or not there is some degree of bronchial hyperreactivity or lessening of lung function. We generally try to find a 20% decline in lung function with the administration of a stimulant like methacholine or histamine or cold air or exercise. All of those can induce a reduction in lung function and simulate the airflow obstruction seen in asthma. In patients who have a history of asthma, such as patients who have chronic allergies and or symptoms such as chest tightness, cough, wheeze, and phlegm production and or cough, those patients may have asthma, and it might require this type of stimulus in order to evaluate for reduction in lung function. Alternatively, one can administer 4 puffs of albuterol and see if there is bronchodilator response. Improvement usually of around 12% plus 200 milliliters of lung function. So in general, to make a diagnosis of asthma, you need to have the symptoms of asthma as well as some evidence of airflow obstruction, either that is reversible with albuterol or that can be induced with one of the challenges mentioned. Let's go on to a second question. Historically, long-acting muscarinic agents or anticholinergic agents like tiotropium have been utilized in the management of patients with COPD, chronic obstructive pulmonary disease. But these therapies were also approved for the management of patients with asthma in 2015. This was on the basis of several trials that demonstrated, both in adults and in children, that addition of tiotropium resulted in improvement in lung function on top of standard of care therapies, such as inhaled corticosteroids and long-acting beta agonists. And it resulted in a reduction in exacerbations in patients who were treated with tiotropium on top of standard of care therapy. In fact, tiotropium has performed comparably to long-acting beta agonists on top of inhaled corticosteroids. So the role of long-acting antimuscarinic agents is to prevent exacerbations and to improve lung function in patients treated with standard of care inhaled corticosteroid and long-acting beta agonist therapy. For those patients, one could consider a LAMA, and this can be given often even before patients are considered for biologic therapies. Let's go on to our next question. Well, this is such an important question. First of all, it's important to treat patients appropriately with different therapies. If you give the right therapy to the right patient, those patients will remain controlled. For anti-IgE therapy with omalizumab, for instance, it's recommended to consider this type of therapy in patients who have poorly controlled allergic asthma, identified by the presence of 2 or more aeroallergens with IgE specificity, and who have IgE levels between 30 and 700. For those patients, there's been shown to have a reduction in exacerbations anywhere from 25% up to 75%. We generally think that patients who are poorly controlled on a long-acting beta agonists and who have evidence of allergic disease benefit from the use of anti-IgE therapy with omalizumab with regard to reduction in exacerbations, reduction in allergic symptoms, and more recently, it's been shown to also be effective in terms of improving symptoms of chronic rhinosinusitis with nasal polyps. Another important consideration with administration of anti-IgE therapy is the fact that it's been demonstrated that patients who are expected to benefit the most are those who have type 2 asthma pathophysiology, patients who've got higher eosinophil counts, higher nitric oxide counts, for instance. Those patients tend to respond better with greater improvements in many of the outcomes observed with anti-IgE therapy. Let's move on to our last question. For most biologic therapies, there's been no significant decrement in lung function or reduction in exacerbations in patients who've been treated with one biologic over another in patients who've got higher BMIs versus lower BMIs. Theoretically, there might be a distribution of medication that is perturbed in patients with high BMI. Theoretically, there's the potential that you need a higher dose to achieve efficacy in patients with higher BMI. But so far, in most of the post-hoc analyses that have been published to date, patients who have higher BMI respond just as well to different biologic therapies as patients with lower BMI. One biologic therapy, reslizumab, is administered based on body weight. It's an IV preparation, and it's shown as excellent efficacy in patients with high BMI and low BMI. But so far, all of the biologic have demonstrated such good efficacy across different BMI ranges. So thank you for joining me during this Ask the Expert session. For additional clinical resources and links to patient education materials, please visit us at www.exchangecme.com. Thanks again.